Greetings, everybody. And today we are at the third global webinar on poverty, hunger, and disability. Before we begin the webinar,
అందరికీ నమస్కారం. మా ఊరు రెడ్డిపల్లి. నా పేరు మల్లేశ్వరి. నా కూతురు పేరు నీలావతి. మేము సాకుల పని చేస్తాము. మేము నీలావతికి ఆమెకు మాటలు రావు, మాట్లాడలేదు. ఆమె తరఫున నేను మాట్లాడుతున్నా. మా పాప బుద్ధిమాంత సార్. మేము ఆ పాప ఎక్కడంటే అక్కడ గడ్డి కూర్చోవటము, లేయటము, పడటము, అట్లే జొల్లు కారడము, కాళ్ళు చేతులు సచ్చు ఏమి చేసుకుంటే కూడా చేత కాదు. మా ఊర్లో వికలాంగుల సంఘం ఉంది. సంఘంలోకి మేము చేరుకున్నాము. చేరుకున్న తర్వాత పునరావాసం అనేది ఉంటే దాంట్లోకి కూడా చేరుకున్నాము. పునరావాస సంఘంలో మా పాపకి కాళ్ళు చెయ్యి సచ్చుండే అవి కూడా బాగా ట్రైనింగ్ ఇచ్చి బాగా చేయించినారు. పునరావాసం కార్యక్రమంలోకి పోయి వచ్చిన తర్వాత మా పాప ఇంటికి వచ్చినాక అన్ని పనులు కూడా ఆమె గిడ్డి వేస్తుంది, ఎనుములకు కట్టేస్తుంది, నీళ్లు తాపుతుంది, పేడగాసు ఎత్తేస్తుంది. మళ్ళీ మా పని మీ సాకరే పోతే బట్టలు ఉతుకుతుంది. ఆమె ఇంట్లో పనులు కసులు నూకటము, ఆయమ్మ అన్నం పెట్టుకొని తినడము, ఆయమ్మ పనులు ఆయమ్మ చేసుకుంటుంది సార్. నేనైతే చేయను ఆయమ్మ పనులు, ఆయమ్మే చేసుకుంటుంది. పునరావాసం కార్యక్రమం గ్రామంలో రావాలని ప్రభుత్వంను కోరుకుంటున్నా. నా కూతురు బాగా అభివృద్ధి అయిన దానికి నాకు సంతోషంగా ఉంది సార్.
Now we have 75 participants tonight, 76, and it's increasing. So greetings and welcome everybody for this IFRA and IDF welcomes you all for this webinar, Poverty, Hunger and Disability, the Missing Link. Most of you would have been part of this series. It's a series of webinar. Most of you would have been part of the earlier webinars. We have done 2 already. But some of you might be joining for the first time. So just for all of us to be on the same page, I would like to highlight some of the important aspects of the previous webinar on this series so that we understand how IFRA is building momentum to bring back the focus on poverty, hunger, and its intense impact on persons with disabilities. This is also a missing link in the global discourse. While we all strive towards addressing the intersectional marginalization experienced by persons with disabilities. The first webinar of the series laid a foundation for this discourse with key leaders from the social movement sharing their thoughts, recognizing the intense impact of poverty and hunger on persons with disability, and have suggested the need to reframe the existing social protection programs like cash transfer and public works program to really have an impact on persons with disabilities, and the need for different income ceiling or measures when we design programs, the need for cross-sectoral recognition of the issues of persons with disabilities. This conversation was strengthened by the contribution from the disability movement that highlighted the missing link in terms of data on persons with disabilities and the extent of marginalization because of lack of services experienced by children with disabilities and adults with disabilities across all domains of their lives. Then the second webinar took stock of the prioritization of this issue in the international community of practice, for example, COSP. IFRA's research highlighted that only 10% of the time and energy of COSP has gone in the discussion on poverty, hunger, and social protection. Further, the webinar delved deeper into looking at evidence on multidimensional poverty, with Monica presenting her work. The argument was further strengthened by presenters highlighting the impact of lack of data and different situations that exacerbate the marginalization of persons with disabilities, for example, climate change, humanitarian emergencies, and so on. Further, the webinar highlighted the way forward in terms of how we look at social protection for persons with disabilities and the need to look at extra cost of disability, living with disability. Taking on the lessons from the earlier webinars, it is critical for us now to unbundle social protection, and look into the key issues of access to services. So here we are to discuss one of the key areas of intervention, which is habilitation, rehabilitation, an equalizer, ensuring full and effective participation. Under this, we are here to highlight the need for community-based rehabilitation to be at the center of our discourse while implementing Article 19 for all persons with disabilities. This webinar is also envisaged to lay the foundation for advocacy initiatives ensuring CBR to be the focus of the World Health Assembly 2023. As a first step, IFRA and IDF, with the support of NCPDP, has produced a report on the status of inclusion of CBR in the WHO call for actions. So towards this, I welcome Christy to present the report.
Thank you, Meenakshi. Greetings, everyone. And as Meenakshi has shared, this study, the review and analysis of Rehab 2030, a call for action towards inputs for the World Health Assembly, was commissioned by the Indian Forum for Rehabilitation and Assistive Technology, the Indian Disability Forum, and the National Center for Promotion of Employment of Disabled People. Next slide, please. Yeah. As we all know, the Rehab 2030, a call for action, is the outcome of a two-day workshop held at the WHO headquarters in Geneva in 2017. For your information, it had 208 participants, mostly representatives from developed countries, 67%, and about 16% from Asia and African countries, and the remaining from the Mediterranean and Pacific countries. The group met to discuss the increasing need for rehabilitation and how important it is to meet the Sustainable Development Goals. And this is one of the 10 actions. Call for action is the outcome of that meeting. I'm not going into details of each of the actions, but you can look into the report and later see that. Let's move forward. Suja, next slide. The objective of the review was to look at whether the Rehab 2030 call is fit to meet the needs of persons with disabilities and their families members, particularly those who are living in poverty and in rural communities. Is Rehab 2030 CRPD compliant? Specifically looking at Articles 4, 19, 20, 25, and 26. Thirdly, what important issues would the WHO resolution address to ensure the call for action is CRPD compliant and it meets the needs of the people, particularly living in poverty in rural areas? The methodology used was a desk review of Rehab 2030 minutes and the various related documents. Next slide, please. Yeah. The findings meeting the needs of persons with disabilities living in poverty and rural areas. The Rehab 2030 acknowledges and highlights the need for rehabilitation due to demographic changes, aging population, non-communicable diseases. It considered rehabilitation as an investment across lifespan and an essential component of integrated health services. It promotes integration of rehabilitation within the health system in countries and introduced rehabilitation guide for the country leaders for integration. It's a very bureaucratic document which actually guides, can be used as a guide by the country leaders on how integration can happen. Rehab 2030 stressed on the need for health financing, health information systems in countries, but most of it was talking about the challenges related to health financing and the health information systems. It highlighted barriers to rehabilitation, particularly lack of policies, lack of infrastructure, workforce, and coordination between ministries, and LMICs, the low and middle income countries, are worst impacted, is what it states. Next slide, please. Yeah. Moving on to the findings, Rehab 2030 uses the International Classification of Functioning definition which is a good and broad definition. But in this Rehab 2030, it has an emphasis on functioning and health condition of individuals. There is a need to bring the individual and the environment together as is specified in the ICF definition as well as in the UNCRPD definition. But however, throughout the document, you can see the emphasis on functioning and health conditions of individuals, ignoring the environmental and the barriers as stated in UNCRPD. The language used generally is condition-specific organizations, user groups, and not necessarily persons with disabilities. Their terminology is appearing only once in the document. Almaty and Asthana Declaration. The Rehabilitation Guide does not stress on community participation and self-reliance of people in planning, organizing of primary health care. Community-based rehabilitation promoted since 1978 by WHO should have been part of the call for action, but the guide, it is not part of the call. It is not mentioned also. The guide instead introduces a new terminology, community delivered services, which is not clarified further in the document. Rehab 2030 says that health system should take the stewardship of rehabilitation because it's a health issue and though it has linkages with others, but a collaborative leadership is required as we all know, disability is multidimensional. Habilitation does not find a place in Rehab 2030. Next slide, please. Yeah. Coming to the second question on alignment with UNCRPD, unfortunately or sadly, there is no mention of UNCRPD or any of the articles in the Rehab 2030 documents. Rehab 2030 highlighted global cooperation on assistive technology and hence finds a link to Article 20, which is on personal mobility. There was a session which emphasized on the need for awareness. It was a group session where there was a lot of discussions and suggestions on creating awareness. There's linking with Article 4 on general obligations. But discrimination, rights, and anything which is mentioned very particularly under Article 4 is not mentioned in the document. Article 25, health. Article 19, living independently and being included in the community. Article 26, habilitation and rehabilitation are not recognized under Rehab 2030. It's not mentioned. Next slide, please. Now, the setbacks of Rehab 2030, as the analysis shows, is that there is no buy-in from countries. There was a second meeting of Rehab 2030 held in 2019 in Geneva, which concluded that rehabilitation in health systems is not a political priority of national governments to make it real for people. In fact, they said only 8 countries had partially tried to implement the rehabilitation guide. A call circumventing Almaty. It does not look at health as a human right or acknowledge the fact that health is not just about functioning, but complete physical, social, and mental well-being as stated in the Almaty Declaration. UNCRPD is invisible. It's a glaring gap. The UNCRPD is the foundation upon which Rehab 2030 which to be built, but it is left out. Lack of poverty discourse, poverty trap, multidimensional poverty, gender dimensions, the need for children, none of this, it finds no mention in the Rehab 2030. There is absence of discourses or even mention of the previous commitments, as I said earlier, whether it is on Almaty or AASTHA declarations, but the WHO resolution 58.23 on CDR, 67.7 on disability, the Global Disability Action Plan 2014-21, which was going on when this workshop happened in Geneva. None of this, the WHO framework on disability, all of this are not mentioned in the document. Next slide, please.
Christy, you have a minute.
Yeah. Next slide, please. So the recommendation is that promote human rights and Rehab 2030 should be in full alignment to UNCRPD, should uphold the principles of Almaty and AASTHA with persons with disabilities at the center. If you look at it, exclusion from governance process, exclusion from their right to take decision on their bodies and on their own health care, all this will lead to inequitable health outcomes. It should build on CDR. CDR has now evolved not only just as an approach towards rehabilitation, the multisectoral approach towards equalization of opportunities and social inclusion of people with disabilities, and increase political commitment and leadership to strengthen health systems for persons with disabilities. These are the recommendations. Thank you very much.
Thanks, Christy. Now I request Radhika ji to make her presentation. She's the founder, managing trustee of AASTHA. Over to you, Radhika ji.
When the COVID-19 disaster struck, there was a question that came in front of many of us. Where are all the people with disabilities? How do we reach out to them and other vulnerable groups in our country? What are the kinds of services, habilitation and rehabilitation services that should already have been put in place if we are to reach out, and if people with disabilities and people living with long-term illnesses, for example, are not to slide back after there has been the huge disruption to our lives. In order to understand this, AASTHA and IFRA embarked on a 1.5-year-long study where we studied 5 community-based organizations in 4 states of India. AASTHA working with migrant populations in Delhi, Ishwar Sankalp in West Bengal working with persons with psychosocial disability on the streets of Kolkata, Jan Swasthya Sahyog in Chhattisgarh, a public health organization working in remote tribal villages, working with people with non-communicable diseases such as diabetes, sickle cell anemia, cancer, high blood pressure, TB. Sadhana in Odisha, working again in the rural and tribal areas of Odisha, and a cross-disability organization. Sanchar, another cross-disability organization in West Bengal, working in the 24 Paraganas on the outskirts of the city. In these organizations and through these organizations, we spoke to 114 people, their caregivers, families, and as well as community workers, as well as the management and the teams of the organizations. We found that most people, in fact, all except for one, were in the informal sector. They were earning their living. Majority of the group earned less than 10,000 rupees a month. That is less than $125 a month. Most of the persons with disabilities that we spoke to had dropped out of school due to inaccessible environments, and more than half the persons with disabilities were not married. They lived in very inaccessible environments. For example, a person living in a rural tribal area in Odisha had to cycle 25 kilometers just in order to get a packet of medication. Or in Chhattisgarh, where the remote villages are only connected to the city with one bus that travels daily. As we talked to people and asked them what were the challenges that they faced in actually their functioning and in participation, they spoke about all the challenges and the intersection of these challenges with the social and environmental factors that affect their lives. The one thing that came out very clearly in our interactions and interviews was a picture of exclusion and discrimination. 81% people spoke about discrimination and exclusion, not only in their interpersonal lives, but also at the institutional level. The other thing that struck us very strongly was the fact that whatever be the limitation in functioning and participation that a person is facing, the mental health aspect of it, the emotional aspect of it is very, very big. The mental and physical aspects of participation and functioning are intricately linked, and that is very important when we are talking about how rehabilitation services should be structured in any country. So, for example, people spoke about feeling of sadness, irritability, restlessness, of constant living with constant tiredness, of pain, of mobility difficulties across all groups, whether they be people with psychosocial disabilities or whether they be people living with tuberculosis and cancer, difficulties in communication. These were some of the big things that came out when we spoke to people about what kinds of barriers they were facing. And then there were specific groups, for example, women. Women had to continue their gender roles even if they were ill and tired and on long-term medication. For some women, marriage was not an option. The elderly with their reduced ability to work and independence and exclusion from the younger members of the family were often facing a great deal of loneliness. As we looked at the organizations and how they worked with these people, we understood the range of strategies that were similar while each worked in their own way. These included, firstly, building trust, a proactive outreach, reaching out to people, going to their homes and in the community rather than expecting them to come to them. A rigorous follow-up, because rehabilitation is a process and not a one-time thing. Person-centric care, sharing knowledge about the condition and how to deal with it so that people can become self-sufficient and independent. Building groups and networks so that people who are largely often isolated can become connected and learn to act together to look out for their rights. A multidisciplinary and a multi-stakeholder approach to rehabilitation where inclusion into various institutions is prioritized. Access to entitlements and influencing change in communities and social change by focusing on inclusion and looking at all the determinants of health and the other factors that affect inclusion. One of the most important strategies here was the community-based workers. And I'll talk about them, people from the community who worked through the organization with and for people with disabilities and those who lived with long-term illnesses. And then Corona struck. And with Corona, people spoke about the most important things that they spoke about was not only did they lose the meager income and tumbled further into poverty, but the lack of food and the diversity of food. For example, water was not available on the streets of Kolkata for those who were homeless, or salt was not available in Chhattisgarh, or vegetables. In Delhi, there was absolutely people who lived from day to day had no food in their homes. This resulted in increased stress in their families, an increase in the feelings of sadness and helplessness, increased fear and anxiety for people who were already living with these conditions and emotions. But despite these huge losses that people faced, people were able to respond to the crisis, and they were able to continue the care because of the strategies that had already been used with them. Support groups and networks that were already in place were activated, and organizations of people with disabilities, groups of people living with long-term illnesses, mothers group were able to organize food, money, shelter, psychosocial support, and connect with relief work. The building and strengthening of community where people were able to reach out to each other and new leaders emerged. the strategy of the organizations to increase knowledge and on self-care and promotion and self-reliance, the involvement of the family, and the focused inclusion in society strengthened the pandemic response for people who would otherwise have been very isolated, and they knew what to do in this situation. Linkages that were already made with official institutions such as health services, education services, government programs. These linkages that had already been made promoted pandemic preparedness and response by the people. Basic needs that were not being met at that point were ensured for all: food, shelter, medication that many people needed. The services also continued
Radhika ji, you have a
therapy,
minute.
counseling. Okay.
You have one.
All right. All these were able to continue despite the fact that there was such huge loss. The CBR workers were at the center of this. They were not only the first responders, but they were also the people in the community who became the first responders during the crisis. Our recommendations here are that countries must invest in a universal design of rehabilitation services where rehabilitation services are available for a large number of people, and yet the specific requirements of people with disabilities, people with high support needs, people living with long-term illnesses, and others are taken care of. We recommend the need for comprehensive rehabilitation care closer to where people stay, because it is a process and not a one-time thing. The importance of mental health care being integrated with these services has come out strongly like never before after this disaster. The need for proactive outreach, since persons with disabilities and people with long-term illnesses will not come constantly to the services. So it is important for this service to reach out to them. The significance of context-driven strategies, understanding the unique needs of poverty, disability, and illness, that intersection in organizing our services. The importance of institutionalizing this cadre of community-based workers who are really our first responders in most instances. The importance of strengthening the support structures, networks, organizations of people with disabilities, caregiver groups of people with living with different illness, so that they can become active during such times. The importance of inclusion of vulnerable groups in disaster preparedness and response. And of course, the state being our largest provider in a way, synergy with the state during disasters. Thank you very much.
I request our next presenter, Dr. Nimmi Rastogi, CEO of Sarthak Medical Care and team coordinator, AAMC, and member of AAMC and member Rogi Kalyan Samiti, and media spokesperson of Aam Aadmi Party, to make a presentation on landscape change in primary health, Aam Aadmi Mohalla Clinic, Delhi. I request, you have 10 minutes, Nimmi.
Thank you. A very warm welcome to everybody who is logged in, and my compliments for Indian Disability Forum and Indian Forum for for Rehabilitation and Assistive Technology. It's a great honor to be addressing, though it's not my subject. But I would like to add value to this webinar by telling you a story about a small idea that transformed into major changes in community health in general. Right, so I'm Nimmi Rastogi. I'm a practicing gynecologist in New Delhi, and I also work with the current regime in Delhi, the government, that's Aam Aadmi Party. So I'll tell you the difference between that idea struck and afterwards. So this is a story about Mohalla Clinic. So Mohalla Clinic, for those who don't understand Hindi, it's like common man's neighborhood clinic. So let's start with the presentation. Actually, Mohalla Clinic is nothing but a small clinic that is that the facility of which are available to people in the neighborhood without any fee or any cost for consultation, for test, for medicines, etc. So that has made primary health very, very effectively delivered in Delhi under this idea. So just a minute. Yeah, so to understand Mohalla Clinic, we have to understand the complicated dynamics of Delhi. Delhi is a highly populated city. It's both a city, it's a state, it's also a seat of power. So Delhi is complicated. Its official population is approximately 20 millions, but unofficial is 26 million, because scores of people come from adjoining states. So it shares its border with 5 states. So people come from those states to work and also come for their health needs to our facilities. So male-female ratio of Delhi is not that good, 866 females per 1,000 males, 9.2 elderly population measuring up to 20 lakh above 60, 30% of the elderlies are living on an income below 10,000 rupees. Rough estimation of people with disability is 2%. LGBTQ identification is approximately 2.6%, and there are multiple stakeholders. There is a central government, there is a state government, there is the municipal government, and they are under different political organizations. So there is a constant rift into delivery of any new health policy or plan. So before Aadmi Party came into power, that's in 2015, before that, government hospitals were overflowing with patients. Primary health centers were non-functional, not effective. Dispensaries were there, but they were inadequate. And factory was flourishing. Private health was very, very expensive. And there was huge dissatisfaction at the level of patients. So what was happening is, even for the primary needs, people were going to tertiary care hospital. For instance, I live in South Delhi, so somebody with fever or cough will go to Safdarjung Hospital, which is not meant for this kind of job. It is meant for serious illnesses, admission, trauma, etc., etc. But there was huge rush in tertiary hospitals and also secondary hospitals. And hospitals were, the care for the critical was also suffering. And one person used to stand in queues for, hours together and losing his day's wages just to get medicine for common ailment for the lack of primary health center. So before we came into power, an organization called Dialogue and Development Commission was established with the sole purpose of understanding as to what problems Delhi has, what can we offer to people if we come into power. So it had 13 chapters, out of which health and education took the major chunk, and I was part of that health task force. And then we called people from all professions, basically health profession, but pharma, nursing, even RWAs, common man, what is the problem? How we can improve the health delivery in Delhi? And after consultation with at least 500 people and representatives, we realized that Delhi does not have effective neighborhood clinics, and something that can easily be done. So a pilot was launched in 2016 January, and Mohalla Clinic was born. So Mohalla Clinic is nothing but a small 2 to 3 room prefabricated Ota cabin. It occupies a space of 650 to 800 square feet. One MBBS doctor who's registered with State Medical Council is there, 2 health assistants, 1 pharmacist, 1 multipurpose nursing assistant, and 1 phlebotomist in the field to collect blood samples and carry the reports. So patient's registration is done on a iPad and the data is stored on cloud. It is free for everybody, not just for people in Delhi, even people from overseas. If they have any small issue with their health, they can walk into a Mohalla clinic. 212 lab tests are free. Consultation is free. A list of essential drug medicine, 110 medicine is available. Though currently, recently, Government of India has expanded that list to 300 medicines. So all that is in the EDL is available in Mohalla clinic dispensary. It's a 8 a.m. to 2 p.m. clinic. It works for 6 days a week. Clinic hours are expandable. If doctor wants and the rush is still there, they can keep on seeing the patients and shut it whenever they want. It's an air-conditioned clinic. And you'll be surprised to know that single doctor clinic manages something between 80 to 200 patients every day. And these are patients with common ailments like, cough, cold, allergy, worm infestation, all kinds of minor things for which an MBBS doctor is enough. Other than that, there is a whole lot of awareness programs are going on, because now we have realized that since patients are coming to us, let us make them aware about communicable diseases, tuberculosis, hypertension, non-communicable diseases, and hygiene. All that is also explained to the doctor by the patients by the doctor. And elderlies, it's very popular with the elderlies, with the women, and with children. In fact, men go for work, therefore, it's
You have a
mostly
couple of
women,
minutes.
elderly, they come to us. And we also have evening OP in some Mohalla clinics. Then Mohalla clinics are also established in schools. We've also tried to establish them in defunct shipping containers. A doctor actually earns quite a decent money, because it's per patient. Doctors are not employed with us. They are just on contract basis. They earn 40 rupees per patient, and the minimum guarantee is 75 patients, whether or not such OPDs has that kind of patients. But on an average, every doctor ends up seeing 125 to 150 patients a day, which is a very big number. And that's how even the pharmacists and nursing assistants are receiving money based on the patients. It is free for everyone, as I told you. Some high-end diagnostic tests can also be requisitioned from Mohalla clinics. As I mentioned, 212 lab tests. You mention a test and it's available. HbA1c is available. Lipid levels are available. MH, which is such an expensive test, that's available. We collect the sample and send it to the lab, central lab, and those labs are on panel, and we pay the labs CGHS rate, but we don't charge a penny from the patients. So we also plan to apply some technology, as in these are mobility-friendly clinics. We also want to establish menstrual pad vending machines, water ATMs, incinerator, and whole lot of plans are there. Right now, 519 Mohalla clinics are functional, though our plan was to establish 1,000 Mohalla clinics, but there were certain challenges. 165 Mohalla clinics were recently inaugurated. There are 265 Mohalla clinics in schools. So these clinics are for health checkup of not just students, their parents, and teachers and the staff. So that increases the number of patients covered by Mohalla clinic. And lady doctors also posted in
Dr.
areas
Nimmi, you
where
should wrap up.
Okay. All right. So it's been internationally acclaimed Mohalla clinic, and because people realize that such a small idea, if nicely implemented, can lead to improvement in primary health in such a way. Government spends as much as money as it used to. Now the impact on primary health is so much that rush on tertiary hospitals has gone down. Worsening of primary health has is decreased, and then now we want to integrate rehabilitation and immunization into Mohalla clinic, and we want to have community participation by way of Swasthya Mitra. So all these are everybody's gains actually. Even in the metro stations, they're establishing Mohalla clinic. So the moot point is that you don't have to look for some very high-end solution for some very basic problems. Some biggest of problems can be solved by simplest of solutions, and Mohalla clinic is one such solution. Thank you.
Our next presenter is Dr. Lauis Paluku Sabuni. He is the country leader of the Leprosy Mission, Democratic Republic of Congo. And as a country leader, his work focuses mainly on supporting national leprosy program, local churches and local organizations of people affected by leprosy and disability. Dr. Paluku will be speaking on the impact of revitalizing traditional healers as community health workers in wound management to prevent disabilities, Democratic Republic of Congo.
Thank you very much. I'm from Congo, DRC, and we speak French mostly, but I'll try my best to speak in English. What I'm presenting here is from our experience in DR Congo as people who work with leprosy affected people. And as you may know, we every day experience wound. Once you work with people affected by leprosy, one of the first and the sad experience you go through is working with people with wound. And this is not only for people affected by leprosy, but also other entities like onchocerciasis, LF, and so on. So I have been working for TLM Congo for 10 years now. And TLM, the Leprosy Mission, work with the Ministry of Health. We work with the local churches, with local communities, and TLM Congo supports 6 provinces out of 26 of the country, where we have almost 18,000 people living with leprosy and disability. And when we empower the local staff or maybe the health system, we train doctors and nurses on how to support people in their community. We set up associations of people affected by leprosy, but also we do support livelihood activities within villages. We also train the local authority in the human rights-based approach, because sometimes they don't feel like they are responsible for what people should be getting. We empower local church. At least local churches are the place where poor people can have some support. In the very easiest way. We have also a new approach of child-to-child approach to help children get familiar with hygiene and safety. So what I can say in brief, wound care in DR Congo is not part of the health system. And our question was, how can we support this issue as it has been left behind by the national health system to make sure we prevent disability due to wound. So we developed a small protocol, very easy one, and the objective was to reduce morbidity and disability due to wounds and ulcers among people affected by leprosy, as well as NTDs like Buruli ulcers, leprosy, Yaws, LF, and so on. The approach we used was recycling traditional healers to make sure they understand what they are doing, because most of the people who used to go to see them, but they were not going to the hospital, the national health system because they were not accepted there. And we were able also to empower them with basic equipment to use to heal wound. And this basic equipment, it is only simple things like soap and water and sugar. So the content of the strategy is there. Traditional healers where we did a census of traditional healers in the remote villages. We then built trust. That is what was lacking very much between health professionals and also traditional healers. We identified needs, strength, and opportunity in this, and developed curricula for training. And also, how many do we have in the country? I think there should be more than that. This is just the idea in the 6 provinces out of 26 we have in Congo. We just did the census of 6 provinces, and we do have 237 traditional healers. We have many more than that, actually. This was the key approach we did, because there was no big trust between traditional healers and health professionals. What we did was to try to remove from the head of the health professionals who have a tradition. I mean, they have a colonial training. They have already colonial attitude. So they have some sneaky acts. They have a colonial attitude, a police approach. So we have to destroy that. So and build the trust so that they can trust the traditional people living there. And then we were able to build trust of the traditional healer themselves by conducting a workshop. In that workshop, we did some reliable activity, and to help them be honest, being open, help them show their integrity in when they do their work. Because what I can say here, traditional healers mainly, they were using very harmful products on the wound, and many people have died because of that. So we had to train them in this approach to make sure they are doing good practice. Then we did identify some strength, and the needs, the strength, and the opportunity. One of the needs was the traditional healer, they don't have microbe. They don't have a microbe knowledge, microbe concept. That was one of the topics.
Dr. Lauis, you have a couple of minutes.
Thank you. They have what the strength they have. They are trusted by the community, and therefore we had to train them of the use of a very simple thing, local thing that they can find there: soap, water, sugar, and rest, and then the wound was healed. So the soap was there to clean the area, and the sugar was put once a day. The dressing was used. We were using the local cloth they have in the house, and they needed to have rest at household. The outcome was amazing. 200 patients in 4 provinces of the study, they had their chronic wound healed in less than months. Traditional healers were trained in simple technique of how to heal wounds, but those who were not healed, they were sent to a hospital. And here you have a case where the wound was a big one, using water and soap. After less than 1 month, that is the wound already healed. Here we have a woman who had a very big wound on his foot. And then after 1 month, you have a very cute and very happy, able to do her work. Here she was a very grueling ulcer. And after one, I think that was more than 1 month, he got skin put on it and graft, what we call it in French, and then she was quite good. So in terms of conclusion, what was missing here was trust. So trust and simple thing can change the lives of many people. This is what I can say in short. You can read the poster in the website. Thank you.
Thank you. Thank you very much, Dr. Lauis. And now, Suja, can you show the next film, please? Suja? Yeah.
అందరికీ నమస్కారము. నా పేరు పద్మావతి. మా ఊరు బుక్కరాయ సముద్రము. నేను దినకూలితో బతుకుతున్నాను. నాకు 3 పిల్లలు. ఆ పిల్లల్లో 2 మగ పిల్లవాళ్ళు, ఒక ఆడపాప. ఆ పిల్లవానికి బుద్ధిమానితము. ఆ పిల్లవాని పేరు నరేంద్ర. నరేంద్రకి మాటలు రావు. దానికి నేను మాట్లాడుతున్నాను. చిన్నపిల్లప్పుడు రాళ్ళతో కొట్టడము, బాత్రూమ్ చేయడము, పాస్ పోయడము, ఎక్కడంటే అక్కడ పోవడము, అట్లా చాలా ఉండేవి. నేను తాడు తీసుకొని కానీ కట్టేసుకొని ఇంట్లో పని చేసుకొని మళ్ళీ ఆ పిల్లవాడిని చూసుకుంటా అంటే ఎక్కడికి పని పోయేది కానీ లేదు. నా కొడుకుకి 10 సంవత్సరాలు వచ్చే వరకు నేను ఏం పనికి పోయేకి నాకు లేదు. నేను ఇంటి దగ్గరే ఉండిపోయినాను. మా ఊరిలో వికలాంగుల సంఘం ఉంటే దాంట్లోకి చేరుకున్నాను. సంఘం ద్వారా పునరావాసం కార్యక్రమానికి చేర్పించడం జరిగింది. దానివలన ట్రైనింగులు అన్నీ ఇచ్చి పిల్లవాడు ఇప్పుడు కొట్టడం తిట్టడం ఏమీ లేదు. అందరిలో కలిసి మెలిసి తన పనులు తను చేసుకుంటాడు. నరేంద్ర ఆటల గుంపులో ఉన్నాడు. బాగా ఆడుతాడు, బాగా గెలుస్తాడు. నరేంద్ర అట్లా పిల్లవాళ్ళు గ్రామంలో చాలామంది ఉన్నారు. వాళ్ళకి పునరావాసం కల్పించాలని గవర్నమెంట్ని కోరుకుంటూ నమస్కారం.
Thank you. Thank you, Suja. Now we'll move on to our next speaker, Dr. Shital Muke. She's a project lead and research coordinator at Sangath, India. For the last 8 years, she's been working in the area of global health and mental health, focusing on integrating mental health services into primary health care. Dr. Shital and her team have developed a COVID-19 safety protocol for implementing mental health clinical trials in healthcare settings. Dr. Shital now will present to us on the topic reducing the treatment gap for mental health problems and increasing demand for mental health services, role of lay or non-specialist health workers.
I'll be more talking about the role of the lay or non-specialist health workers in reducing the treatment gap for mental health problems and increasing demand for mental health services. It's well known that the burden of the mental health morbidity is significant at the national as well as the global level. And according to the National Health Survey conducted in 2016-17, the lifetime prevalence for any mental disorder was 13.9%, whereas the current prevalence was 10.6%. And this proportion of the population having the current prevalence of mental disorder, they require actually active interventions. But on the contrary, the treatment gap for the mental disorders range from 70 to 92% for different disorders, including 85% for common mental disorders and 73.6% for the severe mental disorders. So considering this treatment gap, Considering this treatment gap and addressing this issue, Sangath adopted the task sharing approach for strengthening the mental health services. And while adopting the task sharing approach, we also did some research around it, and we found there is a strong evidence both for the effectiveness of task sharing as a means of delivering a care for a range of conditions across settings, and for the effectiveness of non-specialist providers and health workers in delivering elements of culturally adapted psychosocial and psychological interventions for common and severe mental disorders. Another set of secondary and primary data which we worked upon indicated that the involvement of non-specialist health workers was very useful in delivering the mental health services to the adults with the depression and anxiety disorder, as well as pregnant women and the adults with the post-traumatic stress disorder, the people with the dementia, and their caregivers. Also, we learned that there is a perceived acceptability towards a task sharing approach for strengthening the mental health services and delivering them at community level through the non-specialist health worker, which are again known as the community health workers or the ASHA workers in Madhya Pradesh. Based on these studies, we learned that the task sharing is an innovative way to enhance the access to mental health services, marrying community needs with the health workers' capabilities. So later on, taking this approach forward, Sangath has developed the brief psychological interventions for the lay health counselors, and these interventions had been developed through the premium approach. The premium was initiated in October 2010 with the explicit goal of designing a method for the development of empirically supported psychological treatment, means the treatment which has been developed from the context, within the context where the intervention or the treatment will be delivered. And the important characteristic of the empirically supported psychological treatment was that they were sensitive to the context of the population in which this intervention will be delivered and feasible for delivery by the non-specialist health workers. These non-specialist health workers who do not have any prior training in mental health care, the psychological treatment for depression called the Healthy Activity Program, and for alcohol use disorder called Counseling for Alcohol Problems, in short CAP, developed in 2 phases. In first phase, we identify the different strategies and modeling of the treatment to develop these intervention packages, and later on we implement these packages in the Goa, state of Goa, and we evaluated understanding its acceptability and feasibility. Then these developed to interventions for the depression and the alcohol problems, where again studied using the randomized control trial, where the community health workers or the non-specialist health workers deliver these interventions to the patients with the depression and alcohol use disorders attending the primary healthcare center in state of Goa. And end of this study, we learned that the lay health counselors who have delivered this treatment to the patients with depression and alcohol use disorder, along with the usual care which was available in the facilities, was helpful to reduce the symptoms of the depression, as well as reducing the frequency of the alcohol drinking among the patients with alcohol use disorder. Then this program called Vishram was implemented by Sangath in the Vidarbha, the part of the Maharashtra. And this was a community level program where the non-specialist health workers and lay health workers were trained trained for the 6 months on delivering or the providing the psychoeducation to the community people, and along with these community health workers, we're working with along with the physicians working at the primary healthcare centers. And this study again was a clinical trial where the two group of samples were randomized to the treatment group and control group, where in one intervention group where the non-specialist health worker were meeting to the community people and providing them a psychoeducation as well as them helping them to access the mental health services available at the primary healthcare center. And from this study, we learned that the role of non-specialist health worker in increasing the contact coverage and the mental health literacy was significant compared to the control group. Taking forward this work of the healthy activity program and again the community mental health services delivered through Vishram project, the Sangath brought the innovation of digital technology for training the non-specialist health workers. And what we did in this phase of our work that has been taken place under the Essence program, where we digitize the healthy activity program in a way that the training which we used to provide to the community health workers through the traditional face-to-face training that was digitized and digitized in a way that can be provided through the mobile phones. In initial phase of digitizing this training, we digitize one or two modules of the whole intervention, and we test them with the community health workers called ASHA workers here in Madhya Pradesh state.
Where you have 2 minutes.
Yeah, sure. Where we work with the community health workers delivering these modifying and adapting these interventions for the digital platform, and then along with this training we also developed a remote coaching intervention for the community health workers, where these community health workers will be learning these trainings on the mobile platform. They will be receiving a support from our end where they will be facing any challenges. And through this Essence program, we have trained almost 350 community health workers on delivering the brief psychological treatment for the depression. And based on the work on the Essence through the Empower project, again, we have trained the 1,000 non-specialist health workers called ASHA in Madhya Pradesh for again delivering the psychological treatment for the depression. Another program called Sartha, where we have developed training for the community health workers, and again it has been digitized where the ASHA workers can learn that training and screen and refer the patients with the schizophrenia from community to the primary healthcare centers. The learning from our work is enormous in context to the in context to the community health workers, and we have learned and identified that the community health workers or non-specialist health workers are very important part of the healthcare system, who are working in the community with and for community people, and those can be trained and supported through the supervision, and mental health services can be provided to the community people through the community health workers. Thank you.
I request Professor Dr. Luke DeWitte to make his presentation. Dr. Luke is the president of Global Alliance of Assistive Technology Organization, Research Group Technology to Healthcare, Center of Expertise Health Innovation, The Hague University of Applied Sciences. Dr. Luke will present on on access to assistive technology in rural communities?
I will speak about the role of assistive technology. That is technology that helps people with disabilities or functional limitations to live their life as they want to live it, which is a huge problem. I assume that many of you have seen this very important report of the World Health Organization about, it's called the Global Report on Assistive Technology. And that demonstrates very clearly the size of this problem. It says, well, about 2.5 billion people in the world might benefit from the use of assistive devices. But in some countries, only 3% of these people who might benefit have access to it. In the richest country, it's about 90%, and well, the average is below 50. And that means that we really have something to do, because we know very well that there is a strong correlation between poverty, hunger, and disability. And assistive technology is extremely powerful to break the cycle of poverty and disability, and because it can enable people to go to education, to find work, to live an independent life, to make a living. And there are, well, some good studies demonstrated that if you as a country invest $1 in providing people with assistive devices, the societal return on investment is tenfold. So there is some really a job to be done. And this is a topic that I've been working on with an international group for several years. And I've done quite a few studies, mainly in India, but also in Nepal and Bangladesh. Well, I don't go into details, but an important study was done by an Indian woman who has a severe disability herself, Shivani Gupta, and she wrote an excellent PhD thesis calling Invisible Lives. And that title tells exactly what the problem is. She went into rural areas, into villages, and literally looked for people with disabilities. And I must say, we have found the most terrible, unhuman situations. And that was, well, to a certain extent, we found some similar situations in Nepal, especially in rural areas, but also in other places. So based on these studies, I've been trying to work on possible solutions. How can we solve this? Because the standard is, of course, trying to copy the models we know from rich countries, but they are all based on highly trained professional staff. And however many people you train, you will never have enough in a country like India, but also the other countries I mentioned, to provide the people with professional staff. So we have to think of different models. So we started a project in which we worked with experts from very different countries and tried to develop models based on known experiences and based on our own research. And we also did a study in connection with the World Health Organization about quality criteria. It's not enough to just say, well, here you have the device. It has to meet certain quality standards. So that we have been working on also with an Indian project leader, Gift Norman, a doctor from a hospital in Bangalore, South India. One of the important things that we found in all these studies, and that is not a unique finding, it's common sense, that it's quite a complex issue. You cannot just throw assistive devices into the community. It won't work. You need, on a country level, you need legislative frameworks. There has to be a law that supports things, that gives people rights. Products have to be available. That's a big issue. And we know what can work, and there are many solutions available, but not everywhere. And in most countries, you can hardly get anything. People have to know what's available, so you need information systems, and you need professional advice. But as I said before, you cannot just build it on professionals, because you will never have enough. But you need a system to involve professionals and to give proper advice and support in the provision system. You need service delivery models. You need procedures to make sure that you really get what you need and that it's a solid solution. As I said, you need quality standards, guidelines. There have to be rules on who is eligible for what and what is funded by government or health insurance, or what do people have to pay for themselves. Once you have a device, you also need to make sure that it can be maintained and adapted and repaired when it's broken. Big issue, because that very often is not the case. I've seen many wheelchairs with a broken wheel and just useless. Well, you need a supporting innovation program, health information services. So it is a quite complex thing that you all have to arrange to make sure that people get what they need and that it really works. Well, taking that into account, we think the only way to organize this is through regional assistive technology centers. And not specialized centers, one center for prosthetics and one for wheelchairs, but comprehensive one door centers where people can go for anything they would need. But that is not alone is not enough. You will need what we call health navigators in local communities. And that's an interesting thing we have experimented with in a number of villages around the city of Bangalore, but also in a number of urban slums in the city. We have trained women from these communities who had no medical or whatever training. So we gave them a course of about 2 weeks and trained them to become health navigators. And that's extremely important to have people from the communities because, as one of the other speakers mentioned, trust is a key issue. So we in together with people in the community, we selected these women that might be accepted and might be able to play such a role. We trained them, and they became a kind of first contact with open eyes and ears to look for problems. We started with screening for non-communicable diseases. So initially we didn't look at the assistive devices, but we started, the real basic healthcare issues. And that became a very successful formula. And then we decided, well, now it's time to add this perspective of assistive technology and disability to it. Unfortunately, then COVID came. And the whole project collapsed, basically. I was no longer able to travel to India, but the idea is still really valid and alive. So the idea of this health navigator is that it is someone who lives in the community, is trusted by the community, has good links with this assistive technology center and other healthcare organizations, and actively goes into the community to create awareness, to give advice, information, and to identify people who might need to go to formal services. Because that is one of the big issues. People just don't know. They don't go to all kinds of areas. With a little bit of help, they might find a way in the healthcare system. What we also organized is electronic patient records where all the findings were registered, so that if someone with a problem identified goes to a hospital, the data is available to a doctor or whoever they will see.
Doctor, you have a minute.
Yeah, I know. So how far are we? As I said, we experimented with this. We trained about 15, 20 women. And then COVID made it all collapse. But not only me, but our team, which involves also people from these countries I mentioned, we strongly believe in this model, and I think it's really worth trying it out and rolling it out because it's one of the possibilities to do something without being dependent on high-level trained people, and you make real connections with communities. If we do that and we combine assistive technology with the other healthcare issues that are so important, including the mental health issues that were just presented, you get a model that really operationalizes this concept of universal health coverage. And my conclusion will be let's try to do this and evaluate it at a large scale. So I would hope that our partners among you that are interested in making the next step here. Well, that's what I prepared. Thanks.
Now I request Venki to launch his campaign.
Greetings of the day to everyone. A huge thanks to all of you for being here today to represent persons with disabilities living in poverty, like the people we saw in the video, who need rehabilitation services and assistive technology products in their homes and in their communities. Going to even a rehab center, even a nearby town, is a luxury which they cannot afford. So poverty needs to be recognized as a major barrier for persons with disabilities and their families and addressed. The need for this advocacy has arisen because WHO, which initiated CBR to meet the needs, rehabilitation needs of persons with disabilities in 1978, has gradually reduced its support to CBR. CBR developed as a multi-sectoral strategy through the guidelines, CBR guidelines in 2010, and that is not taken its proper support from WHO. The absence of CBR in 2013 call for action is of grave concern, and also the absence of CBR in the WHO resolution of 2021, highest attainable of standard of health for persons with disabilities, is also of grave concern. It is for the first time in 44 years that CBR doesn't find a place in these two documents on concerning disability. So what do we need to do? All of you know that WHO is governed by the World Health Assembly, made up of 183 countries. The WHA, the World Health Assembly, meets every year in May, and the Executive Committee of Executive Board, which is elected by the World Health Assembly, meets in January of every year to decide on the agenda of the WHA. There is a proposition to pass a resolution in 2023 on strengthening rehabilitation in health systems. So it is of utmost urgency that we need to advocate with the ministers of health, the ministers of foreign affairs in each of our countries, to influence them to ensure that CBR is at the center of the 2023 resolution on strengthening rehabilitation in health system. All of us know how to advocate. We need to write letters to the ministers of health, ministers of foreign affairs, with copy to the permanent mission of our country in Geneva. We will send you a note, an advocacy, and also a sample letter. Suja, could you please display the strapline for the advocacy campaign? We will form a group and we will be in touch with one another, to support one another, to ensure that CBR is not forgotten and people with disabilities living in poverty are not forgotten. Statistics is important in planning and making policies. But statistics is about people, and people are made up of flesh and blood. Look forward to working with you on this great effort. We have a huge mountain to climb, but we can do it. Thank you.
Thank you, Venki. Now I request Ms. Snigdha Salka, President, Disability Activist Forum, West Bengal, to give the vote of thanks.
Thank you. On behalf of the Indian Disability Forum, IDF, and Indian Forum for Rehabilitation and Assistive Technology, that is IFRA, I have great pleasure in proposing a vote of thanks to you all for joining this important webinar today. I am Snigdha Sharkar, mother of a person with disability and a member of IDF and IFRA. My daughter is deaf since birth. She is a PhD student at present. We are grateful to the presenters for sharing the experience of their work in the communities. It is truly inspiring and for policymakers to learn from. We will disseminate your stories as part of our advocacy to include CBR in the 2023 WHO resolution on strengthening rehabilitation and health system. We thank Dr. Nimmi Rastogi, Dr. Lauis, Paluku Sabuni, Dr. Shital Muke, and Dr. Leprosy. Life examples are always enriching. A huge thanks to Meenakshi Amma and Padmavati, mothers of Neelavathi and Narendra, youth with disabilities, from rural Andhra Pradesh, for sharing how timely rehabilitation in their villages has enabled inclusion of their children in family and community life. Their appeal to governments everywhere to provide for home-based and community-based rehabilitation services and assistive technology products in villages is strong, loud, and clear. We thank Ms. Christy for doing the analysis of the WHO Rehab 2030 call for action, a significant contribution to make this framework fit for the purpose of persons with disabilities living in poverty and in rural areas. We thank Ms. Radhika Alkhazi for doing a study of CBR in India to showcase community resilience, contribution of trained community workers for the well-being of people in the community. Last but not the least, I would like to thank our moderator for today, Ms. Meenakshi Balasubramanyam, our sign language interpreters, our translators, Sangath for technical support, and NCPDP for funding sign language and Hindi translation services. And we thank Mr. John D'Souza for the digital documentation. The participation of nearly 100 people from across countries in this webinar is overwhelming and encouraging. We will meet most of you again in the post-webinar sessions in October and in our advocacy group. Our sincere thanks to all of you. We hope to be able to organize webinars in the future. Please do join us then. Good day and good night. Thank you.
Thank you, Snigdha. And we also thank Neelavathi and Narendra for allowing us to have a sneak peek into their lives also, along with their mothers. Thank you.
Thank you to everyone. Luke, Sabuni, Nimmi, and Shital, especially all of you. Thank you.